we have our next speaker, Dr. Priya Desai. She is the director of Desai Group of Eye Hospital, Vadodara, and she's a young cornea refractive surgeon. Priya is going to talk to us about detachment membrane detachment. Over to you, Priya.
Thank you, Dr. Himanshu. I think the slides are not being projected. Yeah, okay. So, thank you very much, and good evening, everyone. Now, detachment membrane detachment, as I would like to call it, as detachment membrane curls. DM detachment is basically a complication usually faced after surgery. A detached detachment membrane can be diagnosed on slit lamp examination as a clear optical space between the stroma and the detachment membrane. So now, how do you classify these curls? So it's a very beautiful classification given that what are the things that you can see the next day if you have had a complication after your cataract surgery or your trab or whatever surgery you're doing. You can see detachment folds, you can have a detachment detachment. Now we further classify detachment detachment into rhegmatogenous, bullous, tractional, and complex. I will be covering each of these after the slides. And after, you can even have a loss of descemetes and a post-endothelial keratoplasty surgery. So rhegmatogenous DM detachment. It's usually seen when there is a break in DM. There is a fluid accumulation between the DM and the stroma. It can also occur secondary to a hole or a tear during insertion of blunt instruments. Also seen as a detachment from Schwalbe's line during trabeculectomy. Clinically, it is seen as an undulating membrane in the anterior chamber. And on an OCT, it is seen as an undulating hyperechoic membrane. So at this point in time, I would like to highlight that certain diagnostic tests are very important. Like, for example, in a DM detachment, if you have an access to an OCT, your things become much easier. And I always believe that diagnostic tests should not be a supplement to your clinical exam. It should be, it should not be a substitution. It should be a supplementation. So only if you cannot figure out clinically whether it's a DM detachment or a fold or a DM loss, ASOCT, I think, probably is a golden tool which is going to help you to decide on what further management you would want to do for your patient. Tractional DM. So if you see the previous slide, you can see the detachments as a curl or a fold, and there is free space between. But if you see a tractional detachment, it's very taut. It's like a tight membrane that you can see. Usually secondary to inflammation, trauma, surgery. There's fibrosis, peripheral synechia, subsequent contraction. And it's taut, it's like a tempolin, and there's no movement on BSS injection. On an ASOCT, the arc length of the cornea is more than the DM. In bullous, it's exactly the opposite. It can be because of a disease process, infection, or inflammation, and it's seen as a convex membrane bulging in the anterior chamber. And in complex, you can have a mixture of all of these. So though we're talking about detachment detachment, why am I insisting on showing you DM folds? Because there are a lot of times we can mistake DM folds and DM detachment, and the management of both is completely different. So how do you see DM folds? DM folds are folds that are visualized like crisscross lines in the posterior stroma and DM associated with hazy or mild loss of corneal transparency. And it can be because of endothelial cell loss, intraocular manipulation, mechanical trauma. And management is usually wait and watch. You wait for the inflammation to subside. You try to evaluate of how you would have probably done this, and topical corticosteroids help to reduce the inflammation. So if you have a if you have DM folds instead of a detachment, you don't have to intervene. You have to wait for the inflammation to go down. And the third is DM loss. So, probably when you're going through your side port, there is a part of DM that you have lost during the surgery. It can be seen while you're using blunt instruments. And the management of a DM loss is very different. If you have a very small DM detachment, which is not in the visual axis, which is not very significant, there's no edema, the visual axis is clear, the patient is not complaining, I think you can wait and watch. And obviously, if it is significant, then you can do an endothelial keratoplasty. After a post-DMEC surgery or a D6 surgery, when you have your lenticule which is not attached properly, this is the kind of picture you see. So Jacob et al. Have classified DM detachment very beautifully. If you have a rhegmatogenous detachment, it can be secondary to a hole, tear, or dialysis. If it is insignificant, observe the patient. If it is significant, do an air injection, drain the fluid, give the patient a position, and wait for, and keep on following up the patient and wait for it. If you have a bullous detachment, it can be because of hydroseparation, viscoseparation, iatrogenic. Observe the patient, and if you feel that the inflammation has gone down, but the detachment is, the descemet is not reattaching, you can probably do a relaxing descematotomy and inject air and give the patient position. Tractional can be because of incarceration in synechiae, long-standing vitreous strands adhering to the iris with contraction. If it is insignificant, again you observe. Significant, you have a healthy endothelium, you do the same management. And in tractional, you have a very taut membrane, so doing a relaxing desmatotomy helps you. So you do a relaxing desmatotomy, inject air, give the patient position, and your DM is going to attach. And if you think that this is an endothelium which is not going to recover, then you have to do an endothelial keratoplasty. And if you have a complex detachment, then I think, for example, if you see your lenticule is not attached, I'll show you an OCT picture where the lenticule is not attached, you have to do a reflotation air injection, and that will attach your DM eventually. So this is one case where an air injection was done. You can see this is a typical regmatogenous DM detachment, and air injection was done. Patient was given position, and the desmets attached eventually. So for certain cases where you think that air injection is not going to work, you can use expansible gases like C3F8, SF6. And this is a post-DSEC surgery. An ultra-thin DSEC was done for this patient. You can see that there's a detached graft, and reflotation was done with air injection. And 1 month post-op, you can see that the desmets is attached very well. So it's a short presentation. I would like to conclude here by saying that a good surgeon is not one who does a good surgery, but a good surgeon is one who also does a good surgery and recognizes the complications on table and knows how to manage them. I think in desmets detachment, it is very important for you to know whether you actually have a detachment or something else, and if you do, what is your type of detachment and how are you going to go about managing it. Thank you.
Thank you, Priya. That was really wonderful. Meanwhile, Prashant is setting up his presentation. I have one question for you.
Yes, sir.
So, how late you can do a desmetopexy? If you get a patient who has come after like probably a month or so, latest how long you can go ahead and try out pneumodesmetopexy or desmetopexy in any form?
I think, sir, if you ask me how early, then I would definitely want to wait for the inflammation to subside. But if you ask me how late, then whenever I see the patient, I would definitely give it a try of doing a relaxing.
If patient comes after 1 month, you still can try?
Yes, at least up to 6 weeks, I would safely go ahead and try doing it. And I think probably the worst thing that would happen is it would not reattach. So I wouldn't mind giving it a try, sir.
Yeah, sure. Vikas, I have one question for you. She showed one of the type was DM lost during cataract surgery, and it's not uncommon that sometimes the surgeon ends up doing a desmetorexis and desmet is lost. Now, intraoperatively, God forbid it happens in your hand, and you have tissue availability in your place. Would you go ahead and do DMEC on the same setting?
Short answer is yes, for sure. In case I am sure that is a DM which is detached. So I think a month back, a friend of mine, he called me up. He said that because I've lost a DM, he's a general ophthalmologist, and I think it will need a DMEC or DSEC. I said, are you sure? He said, yes, I'm very sure it was DM which came out. And I said, okay, fine, we'll see. So next day he said that there's a total corneal edema, but guess what? After 3 weeks, it resolved. So what he thought that it was DM which had come out was actually a capsule. So we have to be very sure that this is DM which has detached. But if it's DM, you are sure, you can definitely think. One thing I would like to add to that is, I think we must not use viscoelastic to reattach the DM. Sometimes, if you have a DM detachment during the phaco, you're doing a phaco and you can see the DM has detached. So I remember somebody discussing long back, and he said that I had injected viscoelastic and continued the surgery. This is very dangerous because if the viscoelastic goes in the interface, this will never get attached. So the very important thing is that we must, not use viscoelastic. And I remember one more instance where somebody said that because this patient needs a DSEC. And this was surgery done around 3 months back. He said it is not resolving. And when I saw, there were DM tags here and there. So we said, okay, and the patient was ready. He said, no, go ahead and do a desmetopexy or DSEC. So, but we just did a desmetopexy and resolved. So even after 3 months, I'm sure that we must have seen patients even after 6 months, 8 months. You can give it a try before going ahead with the endothelial keratoplasty.
There are also, because some anecdotal reports of patients who have definitely lost decimase, and after 2 or 3 months their corneas are crystal clear. So how would you explain this?
God is around. So, so it's very difficult. So maybe there is something about the cornea that we don't know yet. So if we are sure that DMS come out, so maybe there are some backup stem cells somewhere which yet to be seen.
No, you can have, like I've seen patients where the central, maybe even 5 or 6 millimeters is lost. Like nowadays there is this terminology of DWEK or whatever it is. But, and then the patient has recovered. If the peripheral cell count is pretty good or the endothelium to begin with was overall healthy, then the peripheral endothelium can slide over. And I think ASOCT can also help us to show where the DM is there or not there or it's missing. Because it can help us to know what is happening. So I normally would wait even if there is a central DM loss. Many patients will recover, but if you have a patient, let's say, who has Fuchs like picture or Gateta, very severe, other eye endothelium is extremely bad, and then you have a central DM loss, then the possibility of recovery may be low. But healthy corneas, other eye looks very healthy, they may recover. So it's happened to me that I told, okay, you register for surgery, and then because we don't get corneas, when the cornea came, cornea is already clear. So I think sometimes patients will help.
Priya, one question for you. So when you do a pneumodesmatopexy, how do you prevent a glaucoma post-operatively? What care you take, and what do you suggest other general ophthalmologists to be careful about?
So I think anti-glaucoma medications are a must when you're doing when you're doing relaxing. So you have to give anti-glaucoma medications in your post-op regime. And I guess nothing.
And the size of the gas bubble, how much do you keep the size of the gas bubble? Do you do the full chamber fill? Or
no, usually not. 3/4, not more than 3/4.
Yeah, so basically 3/4 chamber fill, intraocular pressure on table should be good enough. And as she said, keep patient on anti-glaucoma medication, and just be aware that there can be still chances of pupillary block, and patient might actually call you up in the night with headache and vomiting and those things. But well, at least it will make sure that DM is attached. Along with that, maybe iris, but DM will be attached.
Sir, am I allowed to ask a question?
Yes, please.
So there was one of my friends who had referred a patient, and he gave me a call saying that there's a decimates detachment, and I want you to see what you can do about it. So he said, okay. And then the patient didn't come for about 15 days, and then he said that the patient has come, and the patient seems okay. It seems like the patient is not complaining anymore. So then we eventually saw the patient, and I didn't see the decimates detached from everywhere. So probably it was a spontaneous reattachment. So how do you explain to this? I mean, if your general ophthalmologist friend refers this patient to you, would you tell them that we can wait for a spontaneous reattachment, or would you intervene, or what do you do if this kind of a situation arises?
So that's very good question. That not every DM detachment requires surgical treatment. The shallow detachments, what we call non-planar detachments, and we can wait for them, especially in the periphery. But having said that, earlier time, our experience of air and those things were not so great. And now with DMAC, DSEC coming, injecting air in anterior chamber is sort of not that alien to us. So my threshold for treatment would be very low compared to earlier it would have been, where I would have waited longer. Now possibly the injection becomes a little more earlier than later.
Okay.
Thank you. Thanks.
Yeah, thank you, sir.
We'll move on, and next speaker.
So can I? Yes, please.
Yeah. So, sir, while doing the surgery, many times, while injecting the ILR, sometime the descent get tear, and generally it happens in somewhere in the central or pericentral area, and the descent get folded over it. So even after putting the air, it may not actually get reattached, and it get actually folded. So is it a good option that we actually fold it, push it back with the iris, spatula or some repositor, because ultimately we are going to touch the endothelium. So how it should be dealt with? Because if it is in center, then ultimately post-operatively there can be, even if the cornea is eventually would be fine, but then astigmatism going to be a real issue. So what we can do, like, is it right thing to reattach with the iris suppositor or some instrument? Because we are dealing with the endothelium
True,
again.
true. So you are talking about the non-planar detachment, I think, which is a larger flap which has got folded, right?
Not the larger, but even smaller one. But if it is in the center, then that's really going to create issue in the long term.
See, now as we keep on doing this DMEC and DSEC, so in those also, in case you have a fold, you can try to tap it on the surface. And in case it doesn't go, you can keep a air bubble low, and then use a reverse sense key. And you can actually nudge it. But even with the surface tap, it comes. But if it's a larger one and keeping it folded is not a good idea. We should try, once you remove the air, put fluid again, it tends to uncurl. So it is very difficult, the flap will not remain folded. If with the fluid, it will definitely uncurl, and then you start injecting the air bubble where it is attached, and come, say, if it is attached at 3 o'clock, and coming in the center, so go in the periphery at 3 o'clock from 9 o'clock, and then you start injecting the air, and then it generally, unfolded. But keeping it folded is not a good idea.
Yeah, that is
Also nowadays with the DMAC and all those things, we have touched endothelium so much. As a cornea surgeon, a controlled touch is not as bad as sometime unaware, uncontrolled touch as a general ophthalmologist you end up doing. But I think endothelium is quite forgiving. But as Vikas said, I think we should be a little careful there.